Our next section involves disorders of carbohydrate metabolism, especially glucose metabolism, and especially diabetes and hypoglycemia. These are the things that we're going to be talking about in our next section. I want to let you know that a lot of the questions on the boards involve diabetic patients. There's new recommendations about diabetic patients, and they put a lot of these patients on the boards, even if it's a surgical case, even if it's a non-medical case, even if it doesn't involve an endocrinologic problem with diabetes. They put a lot of these patients on the boards because we do see more and more of these diabetic patients now because the definition of diabetes has totally changed. So we're going to be talking about that, and we're going to be defining the right way to assess these patients and so forth. So diabetes mellitus is a disease of glucose metabolism abnormalities. Right? You don't metabolize your glucose well, and really there's two types of diabetes mellitus. There's two types, type 1, and which occurs early in life. These patients usually have some kind of infectious process, usually some kind of viral infection, and they have an inflammatory process. Involves the beta cells, and basically after this is called insulinitis. After this insulinitis, they basically get their beta cells wiped out. So type 1 diabetics don't have any insulin, versus type 2 diabetics, where this occurs later in life. The patients are usually, their body mass indexes are increased, they're obese usually. The type 2 diabetics, it occurs later in life, but these patients have insulin resistance. So if you measure insulin levels in type 2 diabetics, you'll notice that their insulin, especially early in the disease, their insulin levels are high. So they ask a question on the boards, well, can you have diabetes with elevated insulin levels? And the answer is yes, type 2 diabetes. Type 2 diabetes is an insulin resistant state where patients have elevated levels of insulin. Now, what happens in type 2 diabetes is very interesting. It seems that obesity is a permissive state. The more weight these patients gain, the more resistant their cells become to insulin. So the more you need insulin, right, to override this resistance. The more you need this insulin at high levels makes these people probably gain more weight. So it's a vicious cycle. They gain more weight because of the insulin resistance. And now, years later, what happens is the beta cells are exhausted, and what happens years and years later in type 2 diabetics, now the insulin levels later, they go down because the beta cells are totally wiped out, not in the sense of type 1 diabetes, they're not fibrosed, but they're so worn out from the constant insulin secretion that then eventually, years later, type 2 diabetics, their insulin levels go down. But generally, type 2 diabetes is an insulin resistant state. So please remember that. That's the big difference with type 1 and type 2 diabetes. There's also some other differences that we have to know about, and then it has to do with worse outcomes. Type 1 diabetics, across the board, if you take type 1 diabetics, they have worse outcomes. If you take their overall morbidity and mortality and so forth, they have worse outcomes. But that's because it's a more aggressive disease. They develop more renal insufficiency and so forth. If you take a patient, though, presenting with type 1 diabetes early on, because the type 1 diabetes hasn't had the disease for a long time, because you can't live without insulin for a long time, they usually don't have any vascular complications when they present to the physician. Versus type 2 diabetics, that basically they could have the disease for many years, and they don't know about it, and then all of a sudden the doctor picks it up, or they develop some kind of symptoms that the physician picks up, And once you diagnose type 2 diabetes, they could have vascular disease, they could have renal failure, they could have diabetic retinopathy right from the start of the disease. So even though overall type 1 diabetics have a worse prognosis, once you diagnose the disease of type 1 diabetes, you know that this patient hasn't had the disease for a long time. And you know that this patient can't present with disease that's been going on for years, so they can't have early vascular complications. A type 2 diabetic can have vascular disease from the start because they've had the disease 5, 10 years. Nobody knows how long they've had the disease. So what does this all mean, though, for us clinically? It means that when I see a type 2 diabetic right from the start, I have to screen this patient for vascular disease, for renal disease, for ophthalmopathy, for neuropathy. I have to look for this disease right away for microvascular complications in a type 2 diabetic. I have to look for it. I have to send them to the eye doctor right from the start. Even if they tell me I've never had any symptoms before and I just diagnosed this patient with diabetes today, I have to send them to the eye doctor right away to look for retinopathy, because this guy may have had the disease 1 year, 2 years, 5 years, 10 years, nobody knows. The patient with type 1 diabetes, once I diagnose the disease, even I know this is a worse disease after years, from the start though, once I diagnose him today, I know this guy can't have the disease for a long time. So what do? I don't look for microvascular complications right away. When do I start looking for microvascular complications? 5 years. So type 1 diabetics, we only start to look for microvascular complications. We only start to send them to the eye doctor 5 years after the diagnosis of type 1 diabetes. So please remember that. The definition and diagnosis of diabetes has changed over the last 7 to 8 years. It used to be referred to as any sugar over 200. Patients have diabetes if they have a sugar over 200, and which is probably right. Anybody over 200 at any time probably has diabetes. Then there was other theories about doing a glucose load and finding a sugar over 200 after 2 hours diagnoses diabetes. But now we've simplified everything. We've simplified everything, and I want you to stick to this definition. No matter what the books say, no matter what everybody else says, this is the easiest way to diagnose diabetes, and this is the more reproducible test. The test is called the fasting glucose, and if a patient has a fasting glucose of equal to or over 126, this patient has diabetes. I didn't say this patient has to be on insulin. I didn't say they have to be on medication, but they have diabetes. That's all that you need to know about this patient. Now, some people say, well, maybe, this test was done one time and it's wrong, and, you don't know what happened before and what this guy ate. Maybe you told him to fast and he didn't. So you want to repeat this test one more time within about a week or two apart, not closer by, right? You want to give this patient about a week or two until you give them, if anything has occurred before that you measured the sugar, well, you want to give a couple of days or about a week or two later until everything, has stabilized, and you want to repeat that sugar again. So really the definition of diabetes is a fasting glucose of 126 or over, so equal to or over 126 on 2 different occasions about 1 to 2 weeks apart. That is the definition of a diabetes, and once this patient has that, they have diabetes and they carry the diagnosis of diabetes for the rest of their life. Now, along with that, if a patient comes to us in diabetic ketoacidosis or hyperosmolar hyperglycemia, now diabetic ketoacidosis is the severe form of type 1 diabetes. Hyperosmolar hyperglycemia is the severe form of type 2 diabetes. Now, if they come to us with any one of these manifestations, we don't have to wait for a second time to check the sugar. They have diabetes. So in the outpatient setting, right, when the patient comes in with minimal symptoms or asymptomatic, the diagnosis is done through the fasting glucose. But if a patient comes to the hospital with diabetic ketoacidosis or hypersmolar hyperglycemia, these patients have diabetes, no question about it. There's no question about that. So that's the definition and the diagnosis. And then they ask us a question about a follow-up of diabetes. How do we follow diabetes? And the answer is the best test to follow diabetes with, to see how you're treating this patient, how this patient is doing, is called this thing called the glycosylated hemoglobin, or hemoglobin A1C. So that is the part of hemoglobin that has glucose residues on. And if I know the patient's glycosylated hemoglobin, I know what their mean sugar is the last 2 to 3 months. So I don't know what happens in the morning, I don't know what happens at night specifically, but I know what has happened, what's the mean sugar that this patient's had over the last 2 to 3, maybe 4 months. So I know if this patient's glycosylated hemoglobin is 6.5, I know their mean sugar in across the board in the last 2-3 months is about 125. That's why a glycosylated hemoglobin of 6.5, this patient has pretty much a normal sugar over the last 2-3 months. I know if this patient's glycosylated hemoglobin is 8, this patient's mean sugar runs about 250, maybe even a little bit higher. So just by that, I know what's going on in the last 2-3 months. It's a very, very important test. And we know now that it's one of the tests that we use to titrate the medication and to tell the patients to use more or less medication based on the glycosylated hemoglobin. It also serves another purpose. If you ask the patient, what their sugars run, they always tell you, it runs, 125, 130. They usually check their sugar only when they feel they're doing well. A lot of patients don't check their sugar when they haven't taken their medications, or where they're eating like a bad meal, what they're not supposed to eat the other day. They don't usually check their sugars after that. And that's why the glycosylated hemoglobin serves to tell us basically, is this patient's sugar running well, or what they're giving us on a spreadsheet when they come in every couple of months, does that correlate with the glycosylated hemoglobin? So it really tells us what the patient's doing with their management. It's a very, very objective way to look at the sugar over the last 2-3 months. Now, along with that, we want to know what the patient's sugars are throughout the day, because if I titrate my insulin levels to the patient's needs, then I need to know what's going on specific times of the day. So beyond the glycosylated hemoglobin, when the patient comes to me with diabetes, I'm going to ask them to check a couple of other things. I'm going to ask them to check a fasting glucose throughout the day, so I know what the sugar is in the morning time, when they get up out of bed, what the sugar is before dinner. So I could titrate my insulin and my sulfonylureas and my other oral hypoglycemic agents according to this glucose level. I also sometimes will ask patients to give me a postprandial glucose. This is a good way of assessing what happens also throughout the day. So I don't want this beyond to go above 200 after meals. I don't want my fasting glucose to be over 126. So if my glycosylated hemoglobin is 6.5 or less, and my fasting glucose that the patient gives me is less than 126, now I'm pretty sure I'm treating this guy really well. Throughout the day, the sugars are normal. I don't get any peaks. I don't get any lows. And my glycosylated hemoglobin tells me that the mean sugar is okay, and that's what I follow. And then I know my medication is just the right amount to treat this patient. So they may ask us also on the boards, what are the objectives of diabetic treatment? So the objectives of diabetic treatment is tight glycemic control. That's the new theory of how to prevent microvascular complications. Now, it's only the microvascular complications that we have a lot of data on. The macrovascular complications, like peripheral vascular disease and stuff like that, we don't have enough data to tell us, does tight glycemic control affect the macrovascular complications? Some studies say yes, some studies say no. So when a patient says to me, you know, what are you doing with me when you really control my sugar really well? I'm going to tell them, I prevent the microvascular complications. I prevent diabetic neuropathy. I prevent diabetic nephropathy. I prevent diabetic retinopathy. Those are the 3 microvascular complications. I also tell them that some studies have shown that it may affect the macrovascular complications, but we're not sure. It seems that cholesterol and other factors probably affect that, probably more than diabetes, and tight glycemic control probably doesn't have as much effect as it does with microvascular complications. So the answer is, what are our objectives? Our objectives are that we do tight glycemic control to prevent microvascular complications. What does this all mean? It means that I want my fasting sugars to be less than 126, and I want my glycosylated hemoglobin to be 6.5 or less. That means that this patient's sugar is normal. Normal means less than 126. So that's my objectives of diabetic treatment. Before I talk about the different treatment modalities, I want to talk a little bit about type 1 versus type 2 in terms of some other issues. And I want to stress that type 1 is an insulin-dependent state. The patients with type 1 diabetes don't have any insulin. The only way to treat type 1 diabetics is to give them insulin. You can't give them oral hypoglycemic agents. There's no way that in the step 2 they're going to give you a type 1 diabetic that needs any form of oral hypoglycemic agents. They only get treated with insulin. Type 1 diabetics need insulin for the rest of their lives, unless they get pancreatic cells transplantation. So basically, type 1 diabetes, insulin for the rest of their lives. Now, a couple more things on that. Patients with type 1 diabetes are usually younger, they're lean, they're usually not obese, and I said once they present to you, they haven't had the disease for a long time. They're usually young people, so even when they come in with diabetic ketoacidosis, they're usually young, so they don't have comorbid conditions, they usually do well. But this disease is a more aggressive disease when you take the disease 10, 15 years later. They're more commonly to develop renal disease and so forth. Another note is this, and it's very important because they ask us a question on the board. Type 1 diabetics, if you take identical twins with type 1 diabetes, only about 50% of them, if one identical twin has type 1 diabetes, only 50% of the identical twin will have type 1 diabetes. So the familial, right, the familial issues, the genetic issues are not very important. 50% in identical twins is not a lot. So it seems that these patients with type 1 diabetes has to do with some kind of environmental infectious process that occurs in predisposed individuals. And I told you, these patients develop insulinitis and then fibrosis of the beta cells. If you compare those patients to type 2 diabetics, if you take an identical twin with type 2 diabetes, an identical twin that has type 2 diabetes, the other twin will have type 2 diabetes 100% of the time. So the genetic issues, right, the familial issues, seem to be much more profound in type 2 diabetes. So when I ask a family history on a patient of diabetes, what I'm really asking about is type 2 diabetes. That is the one that has a more profound evidence for familial pattern and so forth. It's very common in the families. The parents have it, the kids will get it. They may not get severe forms of type 2 diabetes, but severe as the parents, right? But they will have type 2 diabetes, some form of type 2 diabetes. That's very important to know. Type 2 diabetes, you could start off with just diet, with nothing else, just diet and exercise. Modify their diet, lose weight, and so forth. When these patients lose weight, what happens to them is they get less insulin resistant. So that's a way to treat this patient. If this doesn't work, you give them oral hypoglycemic agents. If one oral hypoglycemic agent doesn't do it, you add multiple oral hypoglycemic agents. If you added a couple of oral hypoglycemic agents and you still can't control the sugar, these patients, you put them on insulin. So the type 2 diabetics, they could be on no medication, just diet modification and stuff like that and exercise, or they could be on diet modification. You always have to do diet modification and exercise, right? Or they're on diet modification and exercise plus some kind of oral hypoglycemic agent, sometimes plus insulin. So they could have any form of these medications on board. In type 2 diabetes, you could have like 3 medications, oral hypoglycemia plus insulin, but in type 1 diabetes, it's only insulin. So be aware of that. So that's the comparison of type 1 and type 2. I don't want you to get those two mixed up because they're totally different diseases. I'm going to say last, we're going to do a case a little bit later. Diabetic ketoacidosis for your purpose only occurs in type 1 diabetes. Type 2 diabetes only gets hyperosmolar hyperglycemia. So that's the worst stuff that could happen in diabetic patients. So I want you to remember that, and then we're going to do a case a little bit later just to make sure everybody understands that. So let's go a little further down and talk about a little bit about the medication. And I want to tell you a little bit about the first line drugs to treat type 2 diabetes. So remember, oral hypoglycemic drugs can only be used in type 2 diabetes. So we're only talking about treatment of type 2 diabetes here. So the first group of drugs is right here, the sulfonylureas. Now the sulfonylureas have been around for 30, 40 years. They're wonderful medication. Drugs like glyburide, glipizide, glimepiride, and so forth, these drugs act on the beta cells to secrete insulin. And so basically you increase the level of insulin, and these patients now, their sugars normalize. Now they're wonderful medications. They've been around for 30, 40 years. People have shown that they work, but we know that they cause some complications that you need to be aware of, that they ask on the boards multiple times. So one of the side effects is if they secrete insulin, they cause hypoglycemia. So hypoglycemia with sulfonylureas is common, especially older patients when they either forget to eat or they take extra medication by mistake. The second side effect is insulin causes increase in weight. So the sulfonylureas act on the beta cells, they increase the insulin levels, and these patients now gain weight despite having their sugars normalize. So you control their sugars with the sulfonylureas, but they increase weight. So what does that do to the type 2 diabetic? Where I told you what happens. A patient increases weight, they get more obese, and what happens is they get more insulin resistance. So when you give them sulfonylureas, they gain weight, and now you need more sulfonylureas, and now you need more medication. So it's kind of like a vicious cycle. So that's a big deal. They gain weight, and then you need more medication to treat the diabetes. So that's why now you'll see a lot of people say, let me use as a first-line medication something like metformin that doesn't do this, doesn't cause these kind of side effects, in order to not have the patient gain weight and get into this whole vicious cycle of worsening of insulin resistance. So the sulfonylureas are first-line drugs. They're wonderful drugs, but they have those two big side effects. The third side effect, or I shouldn't say side effect, but the third thing that we have to know about is that all these drugs are renally excreted. All of them, all the sulfonylureas are renally excreted except tolbutamide, right here, tolbutamide. People don't like to use tolbutamide. I know maybe 1 or 2 patients that are using tolbutamide, but it's the only sulfonylurea that is metabolized by the liver. So if I have to use a sulfonylurea, I don't have any other choice, and I have to use a sulfonylurea in a diabetic patient that has renal disease, I could only use tolbutamide. The reason why people don't like to use tolbutamide is because look at this, the doses, 2 to 3 times a day. That's bad. Versus glyburide and glipizide and stuff like that, where you dose once a day. You don't have to dose a couple times a day. So why would the patient take 3 times a day when they could take once a day medication? But the reason only to use tolbutamide, the only question they could ask us about that is, when can we use tolbutamide? When do we use tolbutamide? The answer is, when a patient has renal failure, I can't use any of the other sulfonylureas. I can only use tolbutamide because that's the only one that is hepatically metabolized. So that's the only one I want you to remember as an exception to the rule. Otherwise, you can't use any other sulfonylurea in renal disease. Is renal disease common in diabetics? Of course. This is one of the microvascular complications. So those two things go together a lot. So we have to know this little pearl, clinical pearl, about the sulfonylureas. The second big group that is first-line treatment, in fact, is the drug of choice to start patients on diabetes. Now, type 2 diabetes is the biguanides, and the one that has been studied the most, and the only one you need to know, is metformin or glucophage. So this right here is probably right now the most important drug that you could use in type 2 diabetes. It is a great drug. All the randomized prospective trials showed that the patients on diabetes, type 2 diabetes, that were on metformin, either as a single agent or metformin plus something else, did the best. They had the best outcomes, the lower morbidity and mortality, and so forth. So metformin, for your purpose, is a first-line drug. In fact, most people say start with metformin right now because it doesn't have the side effects that sulfonylureas have. What are the side effects that metformin doesn't have? It doesn't cause hypoglycemia because it doesn't affect the beta cells. What it does is it inhibits neoglycogenesis by the liver. So it doesn't affect the beta cells to secrete insulin. It blocks neoglycogenesis, production of glucose by the liver, and so your sugars probably drop. It also stops the reabsorption of glucose in the GI tract. So it suppresses that. And a third one, it probably facilitates glucose into the muscle. So that's the third thing it probably does. But the mechanism of action that I want you to know about metformin, the most important one, is that it inhibits neoglycogenesis by the liver. And I want you to remember it has no effects on the beta cells. Because it doesn't affect the beta cells, it doesn't cause hypoglycemia. And the second thing it doesn't do is it doesn't cause weight gain. That's very important because you don't get into this vicious cycle that you get with the sulfonylureas. So no weight gain, no hypoglycemias. So that's a great drug. Now, if you use the regular form of glucophage, you have to dose it 2-3 times a day. Maximum dose is about 2-3 grams. It's actually 2.5 grams per day. But you dose that 2.5 grams, you break it down into about 2 to 3 doses. Now, there's an extended release form of glucophage, and people are using this now once a day, so it doesn't make it difficult for the patient to use the extended form because they're taking a lot of other medication, so it's good to take it only once a day. But metformin is the drug of choice right now to start type 2 diabetics. The most common side effect of metformin, that people have to stop metformin is the GI side effects: diarrhea, nausea, abdominal cramps. Now, that's why when you start metformin, you start at low doses and you work your way up. If you give them a gram twice a day right off the bat, this patient's going to get GI side effects and they're going to stop the medication. So these side effects kind of go away. The patient gets used to them after a couple of weeks and they don't bother the patient that much. So start at low doses, increase your dose of metformin over the next couple of weeks to get the patient's sugar to normal, and monitor the patient for these side effects. Now these are the most common side effects. They're not bad though, and patients could live with some of these side effects more or less. The most feared side effect though is lactic acidosis. It's very uncommon, but lactic acidosis, when it occurs with metformin, sometimes carries a very high morbidity and mortality. Some of these patients die. So please be careful. If they give you a patient on metformin and they develop a metabolic acidosis, high anion gap, they're trying to tell you they develop lactic acidosis. It's very uncommon. We don't screen for it, but it occurs. All the studies show that 99% of these cases occurred in patients with renal insufficiency. So metformin cannot be used in patients with renal insufficiency because the fear of lactic acidosis. So please be careful of that. So the bottom line so far, I've told you the two first-line drugs, sulfonylureas and the metformin, you can't use in renal failure. The only exception to that is tolbutamide. So I want you to remember that. So metformin, again, is the drug of choice in type 2 diabetes. So going a little further down, I want to tell you now some of the second-line agents. Now some of these are coming up really fast because they're working really well, right? So you're going to see them maybe first line. And for example, the glitazones. The glitazones, this group here, the glitazones are becoming some great medication here. Rosiglitazone and pioglitazone, Avandia, and pioglitazone is called Actos. Right? These are wonderful medication. They basically sensitize insulin. They sensitize the cells to insulin, so you get less insulin resistance. They're great medications. Now you could use them once a day. They're dosed once a day, so they work very well. And the thing is that you could use them even sometimes with renal insufficiency, so they're good medications. Now there was older medication, glitazone medication, that was pulled off the market, and the reason it was pulled off the market was because the severe liver toxicity associated with this. Now we don't see that with rosiglitazone or pioglitazone. It's very uncommon, but sometimes these patients, you have to monitor them for liver disease. Ever check once ever so often for liver disease, because this is one of the toxicities. But again, it's very rare. It's not like the statins where we have to check, every couple of months we have to check the liver toxicity and so forth. So these drugs work very well. They sensitize the cells, the tissue to insulin. They can be used with renal insufficiency. And right now, even though they're second-line agents, because probably the cost makes them second-line agents, they're coming up to first-line agents pretty quick. The glucosidase inhibitors like acarbose and the meclitinides like ripaclinide and nataglinide, all these are second and third-line agents. They shouldn't be used in everyday type 2 diabetics because they haven't been shown in prospective trials to work that well. If you can't use the other medications, or if the other medications are insufficiently working and you don't want to put the patient on insulin, some people will use things like acarbose to treat the patient, even though this is not as good, anywhere as good as the other medication that we talked about, the sulfonylureas, metformin, and the glitazone oral hypoglycemics. Acarbose and the other glucosidase inhibitors work by inhibiting these enzymes in the GI tract. So basically you inhibit absorption of glucose there. That's how these drugs work. So again, first line sulfonylureas and metformin. The glitazones are wonderful drugs. They're second line right now, but they're coming there to first line. And then all the other ones you're probably not going to use on the boards because they haven't been shown in prospective trials. Now let me just give you an overview A patient with type 2 diabetes could be on a combination of sulfonylurea, metformin, and a glitazone oral hypoglycemic agent. They could be on all of three of those agents, they could be on one of those agents, or they could be on two of those agents. So people will use one drug from a different category of drugs and combine it with another drug from another group, and then add another one if they need to. If their A1C is not well controlled and their fasting sugars is not controlled, they'll add a third one. So in the type 2 diabetic, you could have them on one medication, one of these, like metformin only, and then, you know, if this doesn't work, then you'll add a glitazone, and if this is not enough, then you'll add a sulfonylurea, or you'll add a sulfonylurea before you add a glitazone. All this is game. So basically, it's common for you to see type 2 diabetics now in a combination of 2, 3 medications, and some people will use 4 medications. They'll add to that acarbose or something like that. Most of the experts say, look, you know, use the basic drugs. And beyond that, don't use any of the other ones. If the patient needs any of the other ones, like acarbose, you probably need to go to insulin. So the experts right now are using any combination of metformin, sulfonylurea, and glitazones, and usually they haven't gone to the other stuff that you see that we talked about here, the glucosinase inhibitors and the meclidinides. They're not using a lot of this. It's only special cases, so I don't want you to know much about that. I really want you to focus on the 3 groups that we really talked about. After the hypoglycemic agents, we want to talk a little bit about insulins and insulin preparations. Now insulin is the only treatment of choice for type 1 diabetes. Insulin is commonly used along with oral hypoglycemic agents or alone in type 2 diabetes. So there's no other choice except for insulin type 1 diabetes. But for type 2 diabetes, I told you, eventually 8, 10, 12 years later after the diagnosis, these patients develop the insulin need because all the other medication is not working, and then we have to put them on insulin. We usually try to keep them on some forms of oral hypoglycemic agents, basically to minimize the needs for insulin. The reason that we try to minimize the needs for insulin is because insulin increases weight in patient, and it makes them more insulin resistant in type 2 diabetes. So the types of insulin preparations that we use now are basically 4 types. They belong to one of 4 groups. The first type is the ultra short acting insulin, and this is insulin Lispro and insulin Aspart or Aspart insulin. And these patients, once they inject themselves with insulin, the peak is with minutes, usually with about 15 minutes, and they 5, 10, 15 minutes they have action, and then it peaks about 20 minutes, maybe 30 minutes later, and then it goes away. So these ultra short acting insulins really try to simulate what the patient's pancreas does when they see food. So when you eat, your insulin, your pancreas reads, okay, now this patient's glucose level is high, I secrete X amount of insulin. And that's what you're really trying to do with these ultra short acting insulins. Basically what the patients do is they eat a certain meal and they kind of calculate in their mind how much carbohydrates is in the meal, and then right after the meal they inject themselves with certain units of insulin, ultra short acting insulin, depending on how much they ate. It could be anywhere from 3 to 4 units to 10 units, depending if they ate a high carbohydrate load. So ultra short acting insulin simulates the pancreas in terms of how quickly it acts and secretes insulin after a meal. The older type of insulins were called regular insulins. They were rapid, but they're not as rapid as the Lispro, because their peak action usually is about 2 to 4 hours later, and the duration is maybe up to 4 to 6, maybe even more. And then after this, the regular insulins and the ultra short acting insulins, The third type are the intermediate insulins, like NPH insulin, where the peak action is 6 to 12 hours, and then they go on for about 12 hours. So it was common before the age of ultra short acting insulins. It was very common for patients to take a combination of regular insulin in the morning along with NPH, and then some other dose of regular insulin plus NPH in the afternoon. And if you think about it, the regular insulin, when you take it in the morning, kicks in about 3 hours later, so it takes care of the morning hyperglycemia. Then your NPH kicks in, and it takes care of the hyperglycemia from 12 noon to about 6 o'clock in the afternoon. And then when you inject yourself the second time in the 6 o'clock or before meals with regular and NPH, now your NPH takes care of the first couple of hours there until about 10 o'clock or something like that, 11, and then your NPH at night will kick in the morning hours and then wait until the morning, have an effect until the morning time. So the older way to manage diabetes with the older insulins was a combination of some regular in the morning with some NPH in the morning, and then some regular and some NPH at night. And this is because of the cost differential. This is what most people are taking now throughout the world, a combination of regular plus NPH, short-acting insulin, and then intermediate insulin. And you dose them twice a day. Now these are good insulins, and that's the way we used to manage people until about 6-7 years ago. But when you look at them, because they have a peak and a trough, you get areas in between these insulins where there's not good coverage. So it's very important, because we get areas throughout the day, especially in the morning hours, where there's not good coverage of the hyperglycemia. The fourth type of insulin is the extra long-acting insulin. They call them long-acting, but I call them extra long-acting because things like glargine insulin basically works anywhere from 24 to 36 hours. These are great insulins, and they don't have a peak and a trough. You basically get like a stable state. So when you inject your patient with glargine insulin, you don't get like a peak and then it comes down, but you get like a steady state throughout 24 to 36 hours. And that also simulates the pancreas, because the pancreas, even though when you're not eating, it secretes small amounts of insulin, a basal state of insulin, and then when you eat, you get a spurt of insulin. So now today, the way we try to manage insulin requiring or insulin dependent diabetics, we give them a dose of long-acting insulin once a day, either in the morning or at night, and then in between the meals, they get ultra-short-acting insulin, like insulin Lispro. So they get insulin Lispro with the meals. Right after the meals, they calculate how much they need and they take it, and then they take 1 shot a day of long-acting insulin to simulate the basal state that you get with insulin, with pancreatic secretion of insulin throughout the day. So this seems now to work the best and have the best control of glucose and the tightest control, a combination of long-acting insulin and ultra-short-acting insulin. The only problem with this is now the patients have to inject themselves at least 3 to 4 times a day in order to get this effect. Right? You inject yourself 1 time with the glargine, and then with every meal, after every meal, you inject yourself with the ultra-short-acting Lispro and so forth. But that's the way to go. Now, some of the drug companies, they're saying, well, we don't want to pay for this. This is very expensive. But this is the best way to control diabetes now, a combination of long-acting insulin plus ultra-short-acting insulin with meals throughout the day. That's what you're going to see as you go out into practice over the next couple of years. You're going to see these kind of formats and these kind of protocols.